than they do white people, compounding all those other social factors that occur. And we know that these factors can affect health. I call them stress factors. So all of these stress factors, but the ones highlighted in green, are more compounded in people of color than they are in white people. And there's a thing called the weathering concept that says these stressors, such as transportation worries, food insecurity, state of fear, can wear the human body down at the cellular level, affecting the cardiovascular, the immune, and the metabolic systems. And this weathering concept shows that the telomeres, these green areas on the end of chromosomes, are shorter in people undergoing more stress than they are, or related to the stress that you receive. And you can calculate a chronological age and a genetic age by looking at these chromosomes and the telomere length. Michael Liu, who is a former Maternal Child Health Bureau administrator, said that he described weathering as the chronic stress puts the body into overdrive. It's the same idea as if you keep gunning the engine, that sooner or later, you're going to wear the engine out. And as women get older, we know that, he said, birth outcomes get worse. If that happens in the 40s for white women, it actually starts to happen for African American women in their 30s. He said, the stress of being a Black woman in American society can take a physical toll during pregnancy and childbirth. We certainly see that in women's health. When you look at Black versus white women, Black women are more likely to die from cervical cancer, more likely to die from breast cancer, more likely to die from endometrial cancer. When you look at my field of perinatal medicine, preterm birth rates are 40% greater in Blacks than whites. The mortality rates, the risk of a Black woman dying is 3 to 4 times greater than a white woman related to pregnancy. There's certainly severe maternal morbidity. You didn't die, but you got pretty darn sick. And those rates are 20% greater in Blacks versus whites. And readmission to the hospital after delivery is significantly higher in Blacks than whites. And in those readmitted, there is a significant degree of higher morbidity. The Society of Maternal Fetal Medicine, for which the society that I belong to, in 2017, put out a statement. They reissued it in 2020 after the murder of George Floyd. And they stressed in their society publication that the Society of Maternal Fetal Medicine strongly encourages maternal fetal medicine physicians to be conscious of social determinants of health and inequality, to pursue training in implicit bias and cultural humility, and to ultimately work towards a goal of health equity. Similarly, the American College of OB-GYN in February of 2022 put out a statement that's saying it's racism, not race, that drives health inequities and leads to adverse health outcomes, and that racial and ethnic inequities in obstetrics and gynecology cannot be reversed without addressing all aspects of racism and racial bias. Well, some examples of implicit bias in healthcare are frequently seen in the emergency rooms. Black patients seen in emergency room departments receive less analgesia than white patients when studied, or if you ask friends of yours. Hispanic patients in one study were 7 times less likely to receive opioids in the ER than non-Hispanic patients, even in the presence of severe injuries in this particular study done in 2013. There are examples of bias in pediatric care. Pediatricians provided with identical vignettes, randomly identifying a patient as either Black or white, underwent implicit aptitude testing And those providers who had a high degree of implicit pro-white bias were significantly more likely to disagree with the standard of care and provide opioid analgesics to the patient if they were white. Marginalized populations, such as homeless or people of color, are often not afforded the same treatment. They are often presumed more likely to be non-compliant with their medications, presumed more likely to be medication seeking or having an ulterior motive when seeking care. One of the examples that I often use in this is a patient I had who had sickle cell anemia in pregnancy and was in crisis, went to a hospital, to the emergency room. They were very denied her any pain medications, which can be hazardous. What she needs is pain treatment to stop the process, as well as oxygenation and hydration, and identify underlying cause if possible. But they refused to treat her. So she left that hospital and came to the hospital that I was the attending at. That makes her look like she's drug seeking. That makes her look like, you didn't give me what I wanted here. I'll just go find it somewhere else. And so it feeds into the attitude that they're medication seeking or have ulterior motives when seeking care. And she was very intelligent about the situation. I gave this a very similar lecture, not the same one, at a national civil rights symposium. And in the question and answer period, instead of questions, I got example after example after example of patients or people telling me the situations they had been in the emergency room and where they had been denied pain meds and care. One of the funniest ones, to speak of, is a person who was the civil rights commissioner for the city. And she said, I'm laying on this dirty floor. She had some kind of gallbladder attack, and she's writhing on the floor in pain. And the doctor's trying to tell her how he can't give her anything for pain treatment until I guess it came up that she was the civil rights commissioner for the area. And suddenly, oh, well, yeah, we can give you pain meds. Well, we changed that attitude. And it was just, unfortunately, amusing in one respect, but sad in another. The NPR and Harvard, in conjunction with the Robert Wood Foundation, did a survey in 2017. And they said that problems are amplified by unconscious biases that are embedded in the medical system, affecting the quality of care. They said that in that survey, over a third, 33% of Black women said they had been discriminated against because of their race when going to a health doctor or clinic, and 21% had said that they avoided going to a doctor or seeking health care due to those concerns of racial discrimination. One of the things that is often cited about the association of racial disparities in maternal health care are that Black women have late access to care. Well, this certainly may play a role about one of the roles into that. This gentleman down here is Mark Morial, President and CEO of the National Urban League. And last year, yearly, they do an equity index, but last year, he expressed that in the 2022 Equality Index, that Black Americans are, quote, frustrated and worried about being discriminated against because of their race, and that Black Americans particularly feel the sting of racism in the healthcare system. The index revealed that an overwhelming 8 in 10 Black respondents said that they had been discriminated against. Said that they felt that race influences the quality of care a person receives, and that 2 in 5 respondents said the system had personally discriminated against them. This gentleman here, Senator Bill Cassidy, is from Louisiana, and last year he was asked about the maternal mortality rate in his state. At the time, it was the lowest in the nation. his response was, well, about a third of our population is African American, and African Americans have a higher incidence of maternal mortality. So really, if you correct our population for race, we're not as bad, we're not as much of an outlier as it would appear. Basically, and he went on to say, I say that not to minimize the issue, but to focus the issue as to where it would be. For whatever reason, he said, people of color have a higher incidence of maternal mortality. This is Serena Williams. Serena Williams, as I understand, is pregnant now or has recently delivered, but with her first pregnancy, she had a history of pulmonary embolism before she ever got pregnant. That's risk factor number 1. She was pregnant, risk factor number 2. She had a C-section, risk factor number 3. Those are 3 big risk factors for having a recurrent pulmonary embolism. She experienced symptoms of pulmonary embolism, approached her nurse to let her know about that, and her nurse dismissed her. The system initially dismissed her and said, oh, you're probably just dizzy from your pain meds. It's probably nothing. I just find it astounding that anybody who says I've had a pulmonary embolism before and it feels like I have another one with those significant risk factors that she was dismissed at all. I'm not sure of the story, but I heard that she got on the phone, called her agent and said, get me out of this hospital. And then suddenly things started turning around. But it just goes to show it's not socioeconomic status or awareness or ignorance of things and not reporting things that contribute, are not the only factors that contribute to Black maternal mortality. This is Shalon Irving. She was a lieutenant commander who worked for the CDC, ironically, as a person who studied racial health disparities. She had a C-section at 37 weeks due to a history of prior fibroids requiring recommendations for a primary C-section with her first pregnancy. I should say that during her pregnancy, it was commented upon that she was anxious because she was concerned whether she'd have a male baby or not, because she knew that Black males in our society might be more at risk. It was recently related to the death of Trayvon Martin. And so she was had a lot of anxiety during her pregnancy. But she went on to 37 weeks, had a C-section that apparently was without complication. But then 2 weeks after surgery, she started to have incisional pain and drainage. She went in to be seen by her physician and was seen by not her primary physician, but somebody else in the group who looked at her and examined her and told her she looked okay and that she should go back and go home and come back with her scheduled postpartum visit. And on the way out of the building, she ran into her primary doctor at the door, who looked at her and said, "You look terrible. What's going on?" And so her primary doctor took her back into the office, examined her, apparently identified a draining infected incision, and opened it. She needed to have her incision packed daily, and they sent a visiting nurse out to visit her to see how she was doing. At one of those visits, she had a blood pressure of 174 over 118, which is significantly elevated. A blood pressure greater than 160 over 110 is at risk for stroke and significant compromise. And the nurse advised her to go into the office to be seen. She went into the office the following day, and the blood pressure was lower, her labs were normal, and she was sent home. 5 days later, she returned. She had a 9-pound weight gain that had occurred in 10 days. She had edema and swelling to above her knees, not typical for pregnancy. You might have some postpartum in your ankles, but it should not be at the level of your knees. She stated she didn't feel well, and she was told, "You just had a baby. Give it time. You're just not going to be yourself right away." 3 weeks after delivery, she went in again. She was given treatment at this point for her hypertension. She and her mother picked up the medicine at the pharmacy. Then they went out to dinner, and the baby was with them. It's described that she then went home. She was in the bathroom changing, and her mother was putting the baby to bed. And her mother said that Shalon said, "I don't care what they say. I know my body. Something's not right." Then she had a cardiac arrest and collapse. She died later at the hospital. The hospital said that wasn't an unusual death. They declined to do an autopsy, denied to do an autopsy. So the mother had to pay $4,500 to have her daughter's body taken to another county where an autopsy was done. And she was diagnosed with hypertensive disease of the heart. Shalon Irving had gold-plated insurance. She was highly educated. She worked for the CDC. It just also goes to show that, unfortunately, maternal mortality rates for Black women are not related to where you work, what type of insurance you have, or how educated you are. This is Charles Johnson. His wife, Kira, had a elective repeat C-section that was, quote, botched, unquote, according to the lawsuit that Charles Johnson identified. The C-section was done in 17 minutes, a remarkably short time to be in and out from a C-section and delivering a baby. After the C-section was done and they were in the recovery room, they noticed that there was some blood in her Foley catheter. Having had a C-section with her first baby, they recognized that this wasn't typical and wasn't normal, and brought it to the nurse's attention and doctor's attention, and reportedly a CT scan was ordered. But that didn't happen at all. And she continued to bleed throughout the day. If you have the opportunity, you should look up his rendition of it. It's heartbreaking, but he says that hour after hour after hour went by, and he begged and pleaded, do something. He said she shook ferociously in the bed. Finally, 12 hours later, they took her back to the OR. According to his description, the doctor said, "I'll be back in 15 minutes. She'll be fine." They opened her up. She had 3.5 liters of blood in her abdomen. She coded on the table and died. What was very disturbing to me is that it's described that there were attempts by everybody, him, his family, to advocate for her care, but they were repeatedly ignored. And at one point, Charles Johnson was told by the staff, "Your wife is just not a priority right now." And what's also heartbreaking to me is that his wife, Kira, repeatedly asked him to calm down for fears that he'd be labeled as an angry Black man. I tell people she must have looked like she was dying. She must have felt like she was dying, because indeed she was dying. And he sued Cedars-Sinai Hospital, citing racism as a cause of his wife's death. And from what I understand, that eventually settled out of court. Way back in 1903, W.E.B. Du Bois said, "The problem of the 20th century is the problem of the color line, the relation of the darker to the lighter races of men in Asia and Africa, in America, and the island of the sea." When you read different books and look at racial identity development, there's lots of ways to look at it. This is just one that I put together from different resources that I have. And it starts where everybody sort of, when you're born and you're sort of emulating whiteness and traveling a course to get to an integrative awareness. But that course is by no means a straight shot. You may go up and down, and it depends on which side of this line you are, how you how you address it. And there may be some conformity initially on both sides. There's some acceptance and dismissiveness by white people, blaming or reverse racism, guilt and shame we hear a lot about in the news these days, and then an understanding of white privilege. And for people of color, there may be confusion, dissension and disillusionment, angriness and bitter, and understanding complex identity and sexuality until we get to this integrative awareness. Well, I fashioned myself to be somewhere up here before the murder of George Floyd. And I will tell you, I plummeted back down to disillusionment and angry and bitterness after he was murdered. And I told my husband, I am done. I am done. And he said, oh, no, you can't be. And I was done until I heard a sermon that convinced me that I couldn't be done. And I thought about my daughters that made me realize I cannot be done. And so that is indeed one of the reasons that I do this. And it's by no means a straight course here. And we all sort of travel this road with different experiences and different thoughts and processes at the time, but we must keep moving forward. So implicit biases can compound social and stress factors affecting health and contribute to racial health disparities. It may be better understood as a cognitive manifestation of historical and structural organizational inequalities rather than solely an individual mindset, which suggests that efforts to make it better to remediate implicit biases require attention be given to modifying social environments and not solely to changing one person's mind or changing an individual's mind. Addressing these issues may mitigate disparities in health outcomes. Whether bad or good, justified or unjustified, our beliefs and attitudes can become automatically triggered, affecting our behavior and decision making. It can happen unintentionally, it can happen unconsciously, it can happen without effort, and it can happen in a matter of seconds. It can happen irrespective of our values and irrespective of what kind of person we desire to be. Efforts to mitigate implicit biases that negatively affect healthcare require deliberate intention, focused attention, and persistent mindfulness. It happens on an individual level. It needs to happen on an individual level and on an organizational level. Since we are in the beginning of football season, I often use the analogy that it's like the 2-minute drill in football. Any championship team practices that more than once a year. If a good team will practice it at least once a week, and likely at the end of every practice session, because when it comes down to the stress of I need to score in 2 minutes, you're going to fall back into your old habits if you haven't practiced how to handle that stress and to deal with the new habits that you want to happen. So when I have people, when I give these lectures and they say, well, what my hospital says it's too big a problem, or I don't know what to do, I tell them, use that football analogy, tell them you need more than just one little lecture on it. You need to have repeated examples and consciousness and deliberate intention of looking at this issue. Otherwise, you're going to fall into your old habits. You're going to fall into what you've learned since way before preschool or what's been suggested to you. Deconstructing our unconscious bias takes consistent work. We can't address it once and be done. I also tell people that, well, what can we do? I hear this from white people. I hear this from Black people. It can be discouraging, but I remind them that the only thing necessary for the triumph of evil is for good men to do nothing. And that I'm only one, but I am one. I can't do everything, but I can do something. And I will not refuse to do the something that I can do. I appreciate your attention.
Thank you so much for this excellent discussion of the issue. Thank you so much. And I want to start off with the first question, if it's okay, with my co-moderators. So I was sitting here calm and collected, but as a senior age Black man, I got extremely angry at what you were saying. And I wish I could create 1 million Black doctors to take care of our daughters and granddaughters. Is there anything that can be done? I don't believe it's curable. I don't believe that, for the most part, other races are going to care about what happens with our kids and women. How would you
Well,
address?
I will tell you that I give this lecture to different audiences, and I've been requested by multiple white audiences to come to their areas to give it, and I'm happy to do that. And I know I'm not going to impact all the white people or the non-people of color there, but there may be one or two. I tell people I am an angry Black woman, and there's nothing wrong with that. The Bible says, be angry and sin not. So I'm an angry woman. I want better for my daughters. My daughters deserve better. Your daughters deserve better. Everybody's daughters deserve better. And so while I am one, I'm only one, but I'm going to do what I can do. And I, if I didn't have my faith in God, there's no way. I'd sort of be like, well, we should just give up. This is never going to work, but I can't accept that. I just cannot accept that. I think that and it has to be a multidimensional approach, as you point out. We need more people, doctors of color, and people who look like you and understand you and can relate to you when you go in and have concerns, as opposed to you feeling awkward about talking to them and stuff. So I certainly understand your frustration, and I was there, Dr. Maxey. I was there when I told my husband, I'm done. I'm angry. I'm done. I'm not doing it anymore. And I can't be done. I can't be done. So I would encourage you. And that's what I say to people. And I say that too. And I tell the white people in the audience, really for a change to occur, the white people in this audience are going to have to step up and be heard and make a difference. All it takes for evil to succeed is that good people do nothing. So where do you fall on this issue?
My wife, who is Jamaican, has a saying. It says, "Me done." That's Neighbor Stevens. Any thoughts?
Oh, I have many thoughts about this. One of the thoughts is just the other day, I was listening to the radio in the car, and Michael Jackson's song came on, "The Man in the Mirror."
Amen.
And I said, I haven't, to myself, I said, I haven't heard this song in a long time. It was meant for me to hear this song right now, because I too trying to fall into a point of being desolate and fear of being unable to make a difference. And I really liked one of the lines on one of your slides that said that this is something that has to be tackled at the individual level, but as well at the organizational and the societal level. And I think that's where I'm getting my most frustration, is I'm not seeing how I can be more effective in making a difference, other than when opportunities present at work, in institutions, that I speak up. And I've never been one afraid to speak up. You don't know what effect you have when you speak up, but you got to speak up. My question to you, this very disheartening statistic I read just this morning, actually, is that the number of individuals, both Black and white medical students, choosing to go into the primary care areas is just plummeting. And OBGYN is one of those that's really plummeting. And I think I know it has been impacted by the Supreme Court decision, but I think this started actually before the decision. What are your thoughts? This is not, you made the comment that we need more professionals of color to to be the advocates and to be the warriors. What are your thoughts about how, with everything that's happening and so discouraging, how can we encourage and get more students of color to consider even going into medicine?
I think, one of the things that I do is that I have a program that interacts with young women because I have 2 daughters. And so I'm very interested in making sure they're exposed to a lot of different things. And one of those things might be a field of medicine. Oddly enough, my daughters aren't interested in going into medicine, but I have been interacting with young people. And I think there's different ways to do that. To expose them to whatever, engineering or, veterinary medicine or whatever they may want to decide they want to go into. And I think that's an avenue to do that. I'm on the admissions committee here at Indiana University. And one of the things that I think is important is to advocate for during those sessions where they're discussing who and should not even be admitted to medical school, that they see some diversity in those discussions and the people who they're seeing. But I think there's lots of ways to encourage people, but it may not be I think young people should go into what their passion is and not just to make money and not, because you won't, as you won't do it. It won't be fulfilling if it's just to make money. It's too hard just to make money. But if you love it and you're making money at it, great. And so I think exposing young people to all types of opportunities is important in increasing exposure and things that they traditionally aren't seen as people of color in those fields. Did that answer your question?
Oh, yes. Thank you.
Dr. Walks?
Oh,
I think Bill Lawson's hand's been up for a while.
well, we're going to have to bear with the new tech person.
Dr. Walks or Dr. Hines?
So I'll speak while Dr. Walks is getting unmuted. Thank you for, again, a wonderful presentation. The stories were so heartbreaking, partly because I've seen so many of them, whether from friends or I've had to advocate for people. Like, I've seen them, and which is extra sad, right?
Mm-hmm.
But I also really like the quote at the end about, being one, right? And then even as one, there's something that you can do. I think that since the George Floyd incidents, there's been a whole increase in organizational and corporate DE&I initiatives, and some of them end up being kind of performative art, we'll say. And I was just curious as regard to when we're talking about organizational change, because, we've done something. We had an hour-long session on, implicit bias, or, we require, all medical professions. So in my state, all medical professionals have to do a couple of hours of implicit bias training prior to their relicensure. How to move the needle in that space, right? Because you think you're doing something by introducing the topic, but to your point, just one little blip isn't enough to really make a difference.
Right. I totally agree. I spoke at one conference, the civil rights conference, that one gentleman had a lecture. It was called Only If You Mean It. Don't ask me to be on your committee if you just need a body there. If you don't really mean to do something with this meeting. I am of the age and maturity level that I'm not here to sit back and be complicit and compliant. And I tell people I can't allow you to be complacent. So if I'm in a meeting with that, you're hearing my voice, you're at least going to hear that, well, we need to do more than that. And we need to do this. Whereas I was in one meeting where they kept telling this one person who was the DEI person, you slow down, you're going too fast. Like, we're 250 years too slow. We can't afford to slow down. So, and I tell them, because my daughters deserve more. So what I can do is be a voice, and I think people can be a voice. There are going to be some people and some things where nothing gets done, but I'm the thorn in your side that says, well, we better, at least in this meeting, if I come to it, you're going to hear it from me, and I need more, but it might just be on an individual level. There are encouragingly, I've been asked to go around the state. I did one lecture and people, oh, you said it in such a nice way. God is good. Because sort of, when you start with a fire and you say, oh, people got implicit bias about a fire, that doesn't mean anything. But then you turn it into race, and then it's like, oh, okay. So it catches their attention a little bit, and you do it they thought it in a nice way, but I'm not here to make you feel good about it. And I'm serious about my daughters deserve more, and your daughters deserve more, no matter what race they are, but certainly my daughters deserve more. And so I make that clear in any meeting that I'm in, and it needs to be more. And surprisingly, there is enough mix. That one conference I spoke at the question and answer period, there were people whose daughters had married, people of color. And so now my grandchild is a person of color. And so now I have a little bit more attention and awareness of this issue, and I want to do more. And so you just snatch at people and things as you can. And as I say, trust God that it just has to get better. And I'm here to be a part of that solution and not part of that complacency, and let it keep on going, because I've lost all hope.
I understand Dr. Lawson's hand is up. Is he unmuted?
Dr. Walks is unmuted while I try to get Dr. Lawson unmuted.
Hi, good afternoon. Can you hear me?
Yes, sir.
Okay, thank you so much. I apologize. I had a flight delay and am in the car leaving the airport. But this is really one of the very, very important things that we have got to get done. I spent this weekend at my medical school reunion and had an opportunity to talk with medical students about the impacts that they can make as physicians. And I just wanted to share, first of all, this presentation is absolutely great. It's just what I need to keep my blood pressure up and to keep me angry. And to make me act. And so I really appreciate that. I was talking with the medical students, and this goes back in some part to what Dr. Nabert Stevens raised about what do we do. And I look at an MD degree as a gateway degree. It's a degree that allows you to come to conversations of all kinds with a certain level of acceptance and credibility. And so what I was telling the medical students, some of whom have tried to get involved with policy and been frustrated, I tell them they have to stay in that room, they have to be in those conversations, and they have to make their voices heard. It is critical that if we as physicians have the ability to speak with our elected officials, to speak with the people in power, to sit on admissions committees, it's incredibly important that in addition to the very important clinical work that we do, it's critical that we work in our communities. We can sit on commissions, we can sit on boards of education, we can be visible everywhere and carry our story of this need for equity to every place that we go. So I'm excited about the Black Health Trust having this particular topic addressed in such a clear and useful way. And I just think it's important for physicians to not feel that all we can do is treat our patients well. We can make a difference across the community, leading to some lasting culture change. That's my comment.
Thank you, Dr. Walks. Can we get Dr. Lawson unmuted?
He is
Yeah, I think you can hear me. I just want to thank you for an outstanding, excellent presentation, and also emphasizing, and I want to build on a point that you made about how, in many ways, this is a systemic issue. I've been impressed by the fact, a lot of what you said, there's been research going, way back. People at the psychology department at Howard has been looking at the effect of racism on things such as blood pressure, and it's been published and gone over multiple times. But what's disturbing is that it seems that we have to keep reinventing the wheel. Your points, I'm glad you brought it up in this area. I'm bringing it up now in science fiction. I'm bringing it up in, of course, in psychiatry. We did a study way back when, about 30 or 40 years ago, in which we simply asked a group of white folks in a state that has very few Black people how many Black people were around, and they gave outrageously high numbers.
Wow.
So the question became, and then I'm doing work now showing that we still overdiagnose schizophrenia, even when it's clear that folks have other disorders. So we've got a huge volume of research now. I used to think if you put the information in the right journals and so forth, people look at it and act on it. It's not true. In fact, what I'm seeing, and one of you might say more about this, seems as if there's a reaction against providing this information. Their rationale is that it'll make white people feel bad. I'm seeing black folks coming up with the position that this you're in the dinosaur age. We're past this now, and finding Black folks showing some of the elements of implicit bias. So I'm just wondering, maybe we should not call it implicit bias, because implicit bias means that there's some passive process that's going on in the background, when in fact right now it's much more of an active process that's being seen in all elements of politics, law, as well as medicine, and is potentially lethal to Black folks when we see it in healthcare, in the legal system, and others. So I appreciate your comments. Thank you.
Yeah, no, I will tell you that certainly in some of the forums that I talk to people, and I appreciate the comment by the American College of OB-GYN when it says it's racism, not race, that causes the health disparities in women's health. But people are afraid to say the word racism. And, and I say, if we don't understand the real question, we won't get the real answer. And so the real issue is racism. It's not access to care, and you came in the second trimester instead of the first trimester, and it's just there are all those social factors and all that, those biases that are conditioned into people early on affect racism. And it can be more appetizing for people to talk about biases than racism, but that we all know that's the real issue of what's going on. So
it sounds like we should get rid of the word implicit and just say good old racism and bias.
we could.
Right.
Are there any things in the chat from any of our listening audience, Dr. Neighbors?
I wanted to make a comment and ask the question. Can you hear me? Oh,
Yeah, who's
sure.
that?
Jenny Kane.
And Dr. Combs, you have have your hand up. I've been trying to tell you to unmute yourself. So after Dr. Kane speaks, if you unmute yourself, go ahead.
So now, although we know that racism is a major problem, it's now going to be more challenged by the fact of the Supreme Court case, where it is saying that we use race to give ourselves an unfair advantage when we're trying to just level the playing field. So how do we address this issue now? Because they're trying to, from a systemic standpoint now, unman everything related to the gains that we have had. No one ever says nothing about legacy, because my parents went here, or I donated $1 million, and so I get in. And so how do we tackle that while trying to tackle the racism? Because they're going to try to do the reverse to say, oh, you're trying to get unnecessary, ridiculous help when you don't deserve it.
Yeah, and that's one of the issues now with the admissions committee and when people apply to medical school. And so what they have suggested is that you don't use race necessarily as the issue of why you might have not had an equitable access to medical school or other programs, but that your experiences describe your experiences. And so while that certainly, as you point out, is one avenue related to all the social factors that affect health, we can still address what we can as health providers of of acknowledging that there is and advocating for young women, and then that there are racial disparities in health, and that it's related to factors outside of just the color of your skin, and addressing those things, and encouraging everyone to get the best health care they can, and our colleagues and other people to give the best health care they can. But there are many factors outside of that, you know, Florida, et cetera, that we're going to have to address with those issues of equity.
Dr. Coons?
Thank you so much. Go ahead.
Thank you for this wonderful, stimulating discussion. Your presentation was right on point. This is a very tender subject for me because my daughter is pregnant with twins and she's a high-risk fibroid and all the other things that go with it. She's on 8 medications for bile acids and the usual. But as an anesthesiologist, I think one of the greatest problems, this the biggest fallacy is that, oh, they discovered the bleeding, they took her to the operating room and everything's okay. On the other side of the pendulum, we have watched people, and this is in my private practice over, 30 some odd years, where they're bleeding and you get the blood, you give the blood, they discover where the bleeding's from, but it's too late because you get what's called endotheliopathy, where the vascular is completely washed out and you can no longer maintain the blood pressure. So there is a point of no return, even if you wait until you discover where the bleeding is and you say, okay, we got blood. It doesn't work that way in the physiology of hemorrhage. So, I mean, this maternal hemorrhage thing is really, I think, a fact of time. And it's that people don't take our time as serious as other people's time. I am almost fatigued because I did a grand rounds last week at UC Davis on equity with anesthesiologists, which is really, you got to think of some disruptive kind of way to present it to an anesthesiologist. And I'm going to UCLA this week. But one of the things I like saying is that it's bad care. I don't need you to understand anything else, but it's bad care for a subset of people and you got to fix it. And so I think a lot of the terminology, especially amongst the hospital-based groups, is that they're so confused and the only thing they remember is what the Republican said, the last Republican said. It's bad care. You understand bad care because when you get bad care, one of the things I point out, and this is so hard for us, is that in the archives of surgery, it showed a very persuasive statistic on when minorities, Latinos, and Blacks go into even the ivory towers, the best institutions, the providers that they get are what's called the low volume providers. They get the guy who says, oh, I got a spot on my schedule tomorrow. I'm taking you to the OR and I'll fix your carotid. The reason why they have a spot is nobody else wants them. But we do not have that piece of healthcare empowerment and literacy to ask a question. How good are you at this thing? And so I thank you, but something's got to be a sea change with the way we think and the way we pursue healthcare. And it's got to be on the healthcare literacy scene, and it's got to be on the empowerment, because the doctor is going to take you to do the surgery and you're thanking God, oh, thank God they got an open spot for me. We need to have system 2 thinking where we think again, maybe that's because this guy doesn't do that many of those surgeries. So thank you very much. And y'all pray for my daughter.
Amen.
I'd like to go to Dr. Stephen B. Thomas, but first I'd like to address Dr. Kane, who was the person who invited Dr. Parthos to give this talk. And Dr. Kane is the incoming, she's the president-elect of the National Medical Association, and she represents the interests of more than 40,000 Black doctors across the country. And I'm hoping she will take the challenge of creating a major plenary session in New York and the convention after, where we can address in a final way to get this racism away from our families, our daughters, our grandchildren, et cetera. And I know she will accept that. But I'm interested in Dr. Stephen B. Thomas, University of Maryland. How do you stop this racism, sir? This is your expertise.
Well, first, Dr. Maxey, thank you so much. And what a presentation today. No woman should be dying in childcare. And we have a mission of zero mortality in women's health. And these polls behind me are part of our silver lining from the pandemic. And that means going to where people already have trust. And believe it or not, in the Black community, our barber stops and beauty salons are still places where people have trust. And I've told Dr. Maxey, no self-respecting Black barber will say, I'll get you in and out in 10 minutes. And you know, it doesn't matter how much hair you have. So I got my tam on to reflect the Black Panther Party. We have to speak up and embrace the moment that we're in. Everything is on the table right now. And it's my opinion that in the health arena, it may be the one place where we can all come back together for the common good. There was a moment in the pandemic where we actually all came together out of our silos. We shared data across all these domains, and we made it happen. We closed the disparity gap. And now everybody is rushing back to their corners. So I'm going at my age and my stage in the career, I'm saying, leave it all on the field of play. And that means creating the environment in our own community where we take charge of our own health. These polls back here are not an alternative to medical care. These polls back here are simply a new doorway to medical care. All the advances that we've made, but people still go through the old doorway, the emergency room, the dialysis center, after they already have the disease. So we are training barbers and stylists as certified lifestyle community health workers, as certified lifestyle coaches, so that our community can act on what we now know more than we've ever known and how to prevent these chronic diseases. And the last thing I'll say is this. We had people, medical professionals, come into the barbershops and beauty salons to give COVID vaccines and to deliver non-invasive screenings. Very, very important. People showed up for hesitant for the vaccine. They left hesitant, but they were vaccinated. Why? They were treated with dignity and respect. So we got to go back to basics. And then my last thing is just show you my shirt here. Frederick Douglass. Power does not exceed without a demand. Okay? And we need the medical professionals to use the power they have to demand change.
My husband says that all the time, all the time. Yes, amen.
Dr. Neighbors, we'll recognize Dr. Sherrod, and then we're at the top of the hour past.
Yeah, thank you so much, Dr. Maxey and Dr. Porthras. Thank you so much, Sarah, for such an outstanding lecture. And I thank Dr. Virginia Kane for inviting you. And it's always good to see her. She's my sister. But the Association of Black Women Physicians here in Los Angeles has been dealing with this issue of maternal and infant mortality. And, you know, I think this problem is a structural problem. The problem of racism is structural, and it has to be approached from that way. In order to make any real changes, we have to make some structural changes. We made some advances during the civil rights movement, but that was primarily in the individual arena. But you still got the racist structure there, which has to be attacked. And that's going to take all disciplines in order to change the structure. Now, the other point I want to make is that we looked at data of infants being born by midwives, and that mortality data, it does not exist when you compare the ones that are born by midwives. And we are talking about taking responsibility for our own health. Once they get into the system, it's when you get into the problems with the mortality and all. And so in the state of California, now we actually have legislation requiring doulas or allowing doulas to be paid for being there during the birthing process in the hospital. So I think we need to start looking at this issue broader and from the structural point of view in order to make even more advances in trying to deal with this problem. And I get very frustrated with it because it seems that we make a few steps forward and then, you know, we get all of the things that we've advanced on, taken away. I mean, nothing is done permanently. Look at the Civil Rights Act and then the affirmative action. You know, they give us a little bit and then withdraw it, and you're back, and we're going back to Jim Crow time now. So it gets to be really frustrating, but we can never give up, never give out, and never give in, as Dr. Gaston would say.
Thank you so much, Dr. Scott. If I'd like to ask her if she has some final words before our moderators have theirs.
Is that directed at me? I'm sorry.
Yes.
Yes.
Yeah, I agree with it. It's multifactorial. It's all those social factors in that one slide. It takes more than one target and one direction. We have to work together as a team with a common goal. And, you know, where there's no vision, the people perish. We have to keep the vision in front of us and keep moving forward.
Okay, and Dr. Kane is our new president-to-be. I'll give you some final words before our co-host.
She's muted. Unmute, Dr. Kane.
Okay,
There
I
you go.
just unmuted. Thanks.
She's muted again.
Still on mute.
I unmute and then it mutes on me. So is that Barbara? I don't know if you're doing that to me now.
I'm not doing it.
I have to worry about those Harvard graduates, you know, they
And
need
she's
simple
got, she's got
education.
the red button
Education.
today.
So I think what's going to happen is we're all sort of kind of doing our thing, but we're not as structured and disciplined in terms of having an integrated approach. And I think that we have to really start to critically look at this issue and develop critical partnerships. You know, why is there not a blueprint with our Black Legislative Caucus? Why is there not a blueprint with all of the top faith-based organizations where we are systemically approaching this, as well as the folks like Stephen and others that are in this field, giving us best practices in order to make a difference. And let me just say, when any one of us is successful, we're making a difference. When any one of us is successful, but we don't do it in an integrated fashion, and we're not doing it all at the same time. And we have to have a blueprint in order to do this. So I'm trying to already start now looking at industry to see how we can partner and who are some fierce partners that feel very strongly about this diversity, you know, can join the bandwagon for us. But it takes planning, but I think we're quite capable of doing it. And it may mean that we don't see the results for like 5 years from now or 10 years from now. But we got to start early, and even starting in grade school, really producing our young leaders so that they're ready, you know, in terms of pushing that movement.
Appreciate you. Dr. Hines?
Again, just wanted to thank you, Dr. Dungy-Poythress, for this presentation. I think one of the things that has been repeated throughout all of the commentary is how we can use our individual avenues to, you know, attack this issue, right? And then in doing so, create partnerships. And it's like you said, right? Take those opportunities when they come along to join boards, to be on those committees. Even if you think you were invited for token purposes, it doesn't have to end there. You know, to use your voice to the best of your ability and take those opportunities as they come to be your one. So that was my take home. So thank you.
Thank you. Dr. Ivan Walsh, my doctor.
Dr. Poythress, thank you so much. This is so important. I want to use my final comments to just give another example and maybe add a little something to what has been an excellent presentation and conversation. Anyone who knows me knows I love track and field. And one of my favorite track and field performers was American sprinter Tori Bowie. And I was so saddened to hear that she died in childbirth. And then I began to research and read, and in the public domain, I never treated her, never knew her personally, was a lot of information about her mental health and about the challenges she had with mental health. And sort of everyone knew. And while she was winning American gold medals, it was just look at how amazing she is. But then people documented she was sleeping on the benches in the park, and she was sleeping on the floor in the community center where she lived. And then apparently she died alone in childbirth. There is, to go back to Dr. Lawson's comment about overdiagnoses of folks of color, it's especially dangerous when we diagnose and dismiss women of color that are pregnant or that are being taken advantage of and maybe wind up pregnant because of someone else's I can't even think of a polite word, misbehavior, attacks, what have you. So I just wanted to add the mental health piece to this very important discussion about how oftentimes we are dismissed, how we are undertreated or not treated, because it can be a really huge piece of how we're valued. We're winning gold medals, we're wonderful, we're valued, we're in magazines, we're on TV, we're not winning gold medals, and we're sleeping on a bench, and no one is paying attention to both our mental health needs and our health needs with respect to a pregnancy, and we wind up dead and everyone is sad. We have got to do better and not throw people away when they stop entertaining us. Thank you again.
Thank you so much, Dr. Walsh. That's Neighbor Stevens.
I too want to give my thanks again for bringing us to the table to confront this topic and hopefully to energize us to go forward and to do what we can individually do and as a group do to bring this country to the point where it needs to be.
Amen.
Thank you so much.
Well, thank you so much, Dr. Parthos, for being here with us. Dr. Kane, where's your convention going to be held?
It's going to be held in New York City.
No, the one where you come in.
Oh, that's what I'm saying. It's going to be held in New York City.
Okay.
It's going to be in August of next year, the first week in August in New York City. But guys, also, we've got to give tools to the very folks we want to help. So it's not just the medical care. We really have to be champions of the social determinants of health. We got to give not just people supporting living wages. We want thriving wages for people. We want stable housing. And so for that, we got to partner with our businesses to make these things happen. We just can't talk just the medicine by itself. It
Right.
doesn't cut it.
I'd like to be your greatest supporter in this as we go forward. I'd like to add my compliments also to Dr. Dungy Parthos for the excellent presentation and discussion. I do have the sad duty, I was notified during the call that one of our strong supporters every week, Mr. Dorsey, has transitioned. I'm going to call his wife. That's where we got our machine from, Dr. Wilkes.
Yeah.
And I'd like to end in prayer by praising God, asking his blessings and on his family as they go through this difficult time. Thanks everybody for being with us this afternoon. Have a great, great day. Dr. Neighbor Stevens, the button is yours.
And listen, and tell Dr. Lauren Dungy that she should invite her husband to be a speaker on this program too as well. He teaches diversity and inclusion, and he's a fabulous speaker. So you need to see the combination of the both of them in action.
Good. And good. I'd like to invite Mike Tyson to clean up some of this racism too. You're in charge, Dr. Neighbor Stevens.
Goodbye, everyone. See you next week.
Thank you.
Bye-bye.